Hello, rehab people. Good morning. So I have one disclosure. Denise Schmidlin's daughter is my nurse. So when Denise asked me to do this, those of you who don't know, my nurse, I have a large practice, she controls my entire life. It's up to her whether my day is good or bad. So I could have chosen to say no, stay in bed, enjoy my weekend off, and face the wrath of her daughter Jillian, or wimp out and come here. Here I am, all right? So the task I was given is impossible. I'm going to take you through a whirlwind tour of heart failure. Hopefully at the end of this you'll be better off than before you got here. The other thing I want to do is thank all of you for what you do. I used to be in charge of cardiac rehab at Munson. You're very underappreciated, but your work is critical. So thanks for what you do. Keep doing it. All right, so heart failure. Basically, heart failure is the end manifestations of every cardiovascular disorder. Ischemic heart disease, valvular heart disease, diabetes, hypertension, all that stuff. Basically, most of these patients end up with heart failure at the end. It's a clinical syndrome. It's not a disease, right? It's a syndrome that you all are familiar with. Any functional impairment to either the heart ejecting the blood or the heart filling up with blood, either one of those two things will manifest as heart failure. And the manifestations are what we all know, right? These people are short of breath, they have fatigue, they have limited exercise capacity, they have edema, right? Those are the common things that they have. This is the common physical findings. Those of you who've practiced on the inpatient side will recognize the guy in the upper left. That's a patient who has orthopnea. He has to sit up to breathe, right? That is actually the most sensitive finding, sensitive symptom for fluid retention. So if your rehab patients are telling you they do not like to lie down because they're short of breath, that's a very sensitive sign, a specific sign for fluid retention. Jugular venous distension in the lower right, you can see that in people's neck. And then edema, and I will just tell you, not all edema is fluid retention. There's a lot of meds that cause edema. Some of the diabetes medicines can do it. Amlodipine or Norvasc can do it. So edema doesn't always mean people have fluid retention, but those are the signs we typically see. If you look at the prevalence of heart failure, this is becoming a gigantic problem. It's the most common reason people are admitted to the hospital in the Medicare age group. The number one reason is because of heart failure. If you look at this slide, what you'll see is the group of patients that this is growing the most in are people over the age of 65. And the reason is, when you have an MI nowadays, if you're nearby any kind of reasonable center, you're either going to get thrombolytic therapy or you're going to get shipped to the cath lab and we're going to open your vessel. So very few people die of their MI anymore. People still do, but not as many as they used to. But they're left with left ventricular dysfunction and they end up with heart failure down the road. Or we keep them alive by treating all their MIs, doing a bypass, fixing the vein grafts, and they just develop progressive ischemic cardiomyopathy and worse heart failure. Or you'll see as we talk later about heart failure with preserved DF, they have all of these other things that we end up with that problem at the end. So this is a gigantic problem. If you look at the non-cardiac comorbidities in these patients, very, very common, right? In my heart failure practice, the most common thing everybody has is stage 3 to 4 kidney disease. Extremely common, very difficult thing to deal with, and all these other things, COPD, diabetes, stroke. Basically, your heart failure patient is very difficult to take care of because of all these comorbidities. Right? Heart failure is cardiac cancer. Now, I don't say this to patients, but I say it to you, and I'll tell you why. If you look on the left, right, having heart failure, if you're a guy, is the same as having stage 3B colon cancer, okay? And having heart failure, if you're a woman, in terms of survival, is the same as having ovarian cancer. I guarantee you that if I tell a woman she has ovarian cancer, she's gonna feel way worse than if I say she has heart failure, okay? But the prognosis is identical. It is identical, okay? So heart failure is cardiac cancer. That's what it is. Half the patients are dead at 5 years. I don't tell them that either. But that's what we're dealing with, okay, is this problem. And the other difficulty in taking care of these patients is the disease trajectory. So I just put 3 diseases up here. Cancer is a little bit, it's easy in a sense that people are treated for their cancer nowadays, and at some point those treatments won't work, or the cancer recurs or metastasizes, and then they die. And it's a very quick trajectory down. Frailty is this sort of slow dwindling. They're always a little bit worse, a little bit worse, a little bit worse, constant downward trajectory. The problem with heart failure is the trajectory you see there in red. the patient starts to decline. Then they have an abrupt decompensation. You may see the patient in rehab and say, I was just in the hospital, they took 30 pounds of fluid off. When they went home after that admission, they're not quite where they were, if you look at that graph, before they went in. They're a little bit less than they were. And then a period of time happens, and then they have another decompensation. And then they come back up, not quite as good as when they went in, okay? And it goes like this. So the question is, which one of those valleys do I pull the trigger on hospice? Which of those valleys do I do it? If I did it on the first one, I'd be doing it too soon, right? So which one of those is the last decompensation? Usually you can tell because these valleys, right, these bumps in the road, as I call it to patients, they start to come closer and closer and closer together. So they may get admitted once or twice a year. Now they're getting admitted every couple months. Now they can't even make it for 30 days out of the hospital. Then you can usually tell the end is getting near, and you can bring in our palliative care colleagues and our hospice colleagues, all right? So there are different heart failure phenotypes, right? Phenotype's just a word for how it looks, right? So there's different ways to think about this. This is the sort of 30,000 foot view. You have heart failure with the reduced ejection fraction, or what we call systolic heart failure, or HFrEF, heart failure reduced EF. That's usually patients who have an EF of less than 40%. And then we have heart failure with preserved EF, or HFpEF, we call it, or it used to be called diastolic heart failure. And these are people with an EF of 50% or more. The problem is there's a group of people called advanced heart failure. I'll talk about that a little bit. These are people with very advanced systolic heart failure. Then you've got what's called HFmEF, heart failure with mid-range EF. Their EF's 45, 48, right? It's not less than 40, it's not greater than 50. And then you've got this group of patients, which are people who come to me with an EF of 25%. We do our thing. Now their EF is 60%. So their heart failure recovered EF. What happens with those patients, right? So patients fit into all of these different phenotypes. They usually fit into one, but sometimes they'll move between phenotypes, and you have to treat them differently as you go. So we'll start with systolic heart failure, or HFrEF, or heart failure reduced EF. So what happens to this patient? Basically, they have a normal heart, and then something happens, okay? They have an MI. They get exposed to a cardiac toxin like doxorubicin for breast cancer. They get a viral infection, acute myocarditis. Something happens to damage the heart. And then what happens, if you see, look on the far right, the heart remodels in a very disadvantageous way. It gets bigger, okay? The walls get thinner. The papillary muscles get pulled down, so the patient starts to get mitral regurgitation because of that. That mitral regurgitation starts to overload the left ventricle even further, and the cycle just goes and goes and goes, and these people's hearts get worse and worse and worse. So that's what happens. You know, that's what happens sort of pathologically. What happens physiologically is here. So if you look on this slide, just if you look at the left side, that's the good stuff, okay? That's the natriuretic peptide system. And that system releases all of these things that are good for you. They reduce your blood pressure, they reduce your sympathetic tone, they reduce aldosterone levels, all those kinds of things are good. When people have heart failure, when they have some injury to the heart that reduces the ejection fraction, reduces the functional capacity of the heart, this stuff on the right side happens. And that's all bad stuff, okay? Angiotensin goes up, vasoconstriction, blood pressure goes up, sympathetic tone goes up. All that stuff is a response to ventricular dysfunction. It's just a bad response. It's a good response to keep you alive for a while, but it's not a good response to keep you alive for a long time, okay? And that response probably comes genetically. If you go back, when you're a caveman, the most likely thing to kill you is bleeding, right? You get saber-toothed tiger bites you, something happens, you start bleeding, okay? You need the stuff on the right to happen so you don't die quickly, okay? But if you live in the United States and we take care of you and we treat your MIs and we put in defibrillators, we do all this stuff, the stuff on the right is bad for you, okay? So that's the situation you're dealing with. And in heart failure, you have this imbalance between the good and the bad, right? Now, what are the goals of treating patients who have heart failure reduced EF? It's very simple. Two things. We want them to have a better outcome, live longer, feel better, and we want to reduce congestion. Congestion is the problem in these patients. And the way we do that is what's called, we call GDMT, Guideline-Directed Medical Therapy, okay? Or Guideline-Directed Management and Therapy. We'll run through that quickly. This is it, okay? This is the bottom line right here. And the reason I make this as a pyramid is because the stuff on the bottom is stuff everybody needs, and the stuff on the top, a transplant, an LVAD, hospice, is stuff very few people need, okay? But if you look at the bottom, the number one thing these patients need, and you can actually help in this if you learn about this, is they need self-care, okay? This is very similar to managing diabetes, okay? You have to teach the patient what they need to know. Then there's a group of medicines that we use. We'll run through those very quickly. Then you guys are right there, right near the bottom of the period. Cardiac rehab is critically important. And then we got all this other stuff that we do. We put in defibrillators, we put in an LVAD, we give them these medicines, we do all these different things. And all those things are fine, they just don't apply to the great majority of patients, okay? So if you look at what kind of effects we get from our meds and from a defibrillator, this is very simple. If you start someone who has systolic heart failure on an ACE inhibitor or an angiotensin receptor blocker, you will reduce their risk of dying in the next 2 years by about 38%, okay? If you add a beta blocker on top of that, it reduces it even further, and if you throw in a defibrillator, it reduces it even further, okay? That's why all of our systolic dysfunction patients who are candidates, they're getting all this stuff, okay? That's the first thing I tell patients when I see them. I actually explain it to them historically. I say, if you rewind the clock 40 years, when a patient like you 40 years ago, you would have gotten some water pills and a prayer. That's all you get because you weren't going to live very long and that's all there was to it. Then lisinopril, captopril, those kind of drugs came along. Now we actually had treatment that led the patient to do better. They actually lived longer. Some people's hearts got better. Okay, so now you had a treatment that helped. We added that on top of our diuretic therapy. Then the next thing that comes along was the beta blocker. And we found layering a beta blocker on top of an ACE inhibitor and ARB led to even more improvement, just like this slide shows. Then the next thing that came along was a defibrillator. And then since then, there's been some other things, spironolactone, and now we use a lot of Entresto. But explain to the patient, these are additive treatments. And I tell them you're going to take 4 or 5 medicines for the rest of your life. You got to tell them up front, okay? And I tell them when it comes to heart failure, taking more medicines actually doesn't mean you're sicker, okay? Because the sickest people can't take any of these drugs because their kidneys won't tolerate it or their blood pressure won't tolerate it. So that's kind of how it works. This is a real patient. Hopefully this will work. Okay, so on the left side, I apologize, it's kind of choppy, but on the left side was the patient before medical therapy and a biventricular ICD, and the right is the heart afterwards. And the bottom line is you can put the patient's current heart almost totally inside their left ventricle, their old left ventricle, okay? That's how much smaller the heart gets and how much stronger the heart gets, okay? Now, does everyone respond this way? No, but some people do, okay? ICDs, this is pretty straightforward stuff, right? So the first 5 beats are good, the next 100 beats are bad, right? That's basically the problem here, all right? And this is something you have to explain to patients because there are some patients that get very freaked out about thinking about a defibrillator, okay? And what you can do for patients is to help them understand, because most patients get an ICD, they get an ICD as a prophylactic device. So I say to patients, when I get in my car, I put on my seatbelt. Okay? I put on my seatbelt not because there's a high chance I'm going to get in an accident. There's actually a very low chance I'm going to get in an accident, right? But without my seatbelt in place, my chance of surviving is less. It's exactly the same with this, right? If you took 100 people who got a prophylactic ICD, 100, and you follow them and you put an ICD in all 100 of them, in 5 years, over the next 5 years, how many people do you think that ICD would have gone off? 100 people over 5 years, okay? 7 people, okay? It would have gone off and saved their life. Now, would it have gone off in some people inappropriately? Yeah, it would have for AFib or some of these other things. But the bottom line is 95% of people who get a defibrillator, nothing ever happens, right? I mean, I drove down here this morning. We drive all over the place. I put my the chance of getting an accident is very, very low, right? And that's what these people need to understand. When we first started putting ICDs, we had some people who became completely incapacitated, walking around with this thinking any second now I'm going to get popped by this thing, okay? It just doesn't happen, okay? And then after they get popped by it, sometimes it happens. But before that, it doesn't, all right? And so I always tell people this is to protect you, okay? Certain devices, the biventricular devices may make them feel better, but basically it's to protect them. And that's what it's for. You must, in your profession, in your part of our world, you must know the way their defibrillator is set. One of our exercise physiologists found this out the hard way during a cardiopulmonary exercise test. She didn't know this guy had relatively slow VT. He was set to start delivering therapies at 150. He's doing the treadmill thing. He's feeling good. She's doing the Borg scale. He feel good. Go up, 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 and then bang, he starts getting popped. Bang, bang, bang. And the first shock, of course, made him even more upset, right? So his heart goes even faster. He just got repeated shocks till we put a magnet over the device to get it to stop. So I always tell our exercise physiologists who are doing our exercise testing to talk to our ICD team and make sure they know where this patient is set. Most people have a prophylactic device. It's not going to do anything until their heart rate gets very, very high. But there are some people who have it programmed at a lower therapy delivery rate because of their particular VT if they've had it before. So I think that's an important point to know. But these things work quite well. Self-care strategies, can you help people? So first thing, these people take a lot of meds. Right? Half of my heart failure patients take 10 medicines or something, 10 or more. Compliance is not very good in this group of patients because it's just a lot of stuff to manage. All right? So we have a whole team of nurses that work with me that help do just this stuff. Dietary sodium, everyone gets all freaked out about this. I basically tell people 2,000, 2,500 milligrams is fine. Fluids, a couple liters a day. Most people, that's not a problem. If they come to the visit with a super big gulp and they're sitting there talking to me with it, then I may talk to them about it. But for most people, this isn't a gigantic deal. And then daily weight. So what I tell people is this. When you get on the scale and it says 200 pounds, I say that's the weight of your bones, your muscles, your organs, your fat, and your water, okay? If that changes quickly, so I always say the same thing. Let's say you went out and had Chinese food, which you should never do, right? So I tell heart failure, you should never do it. But so you say, you know what, I don't care what Dr. Recchia says. We're going to Chinese food, you go to Panda Express or whatever, and tomorrow you weigh 202, you did not make 2 pounds of fat overnight. That is impossible, okay? It is impossible, okay? That's all fluid. And if we don't do something to fix that fluid right away, it's going to get worse. And then it goes up and up and up. I can't tell you how many people I admit to the hospital who bring their weight chart with me, and they have meticulously written down their weight, and it goes up and up, and they just keep writing it down. It's going up and up and up and up. And so I always tell them, if you gain 2 or 3 pounds, you must call us. You must call us, okay? We have actually a little chart that we use to help them understand that. And the other thing is, when they call us, you have to know to tell them what to do, okay? So that's where our nursing team helps us in that group of patients. So this is advanced heart failure. So this is the ventricle. The key thing about this type of patient. So this is, remember I showed you the phenotypes, right? We had systolic heart failure, and then there was that little circle of advanced heart failure. That's this subgroup of patients. This group of patients, their ventricle gets very spherical. So your left ventricle is actually shaped like a bullet. Think of it like a bullet. But like you see on the left. But when it gets bad, it starts to become like a basketball shape. And then all the geometry and all of the physics that goes with that it really makes it very disadvantageous for that patient to be able to maintain the cardiac output. These patients have what we call stage D heart failure. They're usually cachectic because they can't get enough blood flow to their muscles. They're almost catabolic. They're hospitalized all the time. They're never going to be in a rehab. You're probably almost never going to see a patient like this in rehab. They can't tolerate our meds. Their blood pressure is too low or their kidney function's poor. Right ventricle doesn't work. They have something called cardiorenal syndrome, which is a problem where they clearly have too much fluid. As we try to take the fluid off, the kidney function gets worse. It's like an impossible situation to deal with. And then they also have this cachexia, right? So there's only 3 treatments for this group of patients, okay? Transplant, LVAD, or hospice. That's it. Those are the only 3 treatments, okay? If you look at transplant, this just shows you the survival of over 100,000 transplant patients. The conditional survival, meaning if you survive the first year, you get through the operation, is about 13 years, half the patients are dead, right? You don't think about that, right? But if you have a 30-year-old guy that you transplant, his chance of being alive at 43 is only 50-50, okay? So transplant is not a cure. It's what I always tell patients. It's not a cure for your problem. We're just substituting heart failure for immunosuppression. and everything that goes with having your immune system totally whacked down for the rest of your life, okay? That's really what we're doing, okay? And if you look at what these patients die from, that's the stuff they die from. Bad infections or certain cancers, because your immune system surveils your body for little cancer cells and gets rid of them, and these people have that problem. So transplant's clearly the best option for these patients, I'll show you, but there's some issues with that, okay? This is the problem. You have about 700,000 new heart failure cases a year. You have about 25,000 patients who could get a transplant, and you have 2,500 donor hearts. That number, 2,500, has been the same since when I was in medical school, which was a super long time ago. Okay? It's been the same exact number. Okay? We don't have mandatory donations in this country, and so that's the number. Okay? So, somebody said it to me like this: proposing heart transplant as the cure for heart failure is like proposing the lottery as the cure for poverty, right? It's the same. The lottery is not going to cure poverty. It's the same as this, okay? So transplant for the right patient is there if they can get one, all right? This is a better option right now. This is mechanical circulatory support, or left ventricular assistance device, or LVAD. This is basically an implanted pump that's basically plugged into the apex of the left ventricle. If I can do this right here. It sucks the blood out of the left ventricle and pumps it into the aorta, okay? This is your idealized patient with one of these, okay? The thing has to have power, so there has to be a wire coming out through the abdomen to the battery, to the controllers, and to the battery packs. These patients are completely dependent on power, okay? One of our patients died when he accidentally disconnected both of his batteries at the same time. And so one of our patients tried to commit suicide like that too. So, but this is how it works. And there's 4 ways you can use this device, okay? You can use it as a bridge to transplant. So a young person's got a bad cardiomyopathy, they're failing, they have stage D heart failure. They're not going to be able to we can't take a transplant off the shelf, but you can take this off the shelf. So I send them down. Usually I use the Spectrum team or the Ann Arbor team, sometimes Henry Ford, the 3 LVAD centers in the state, to talk about this, and as a bridge to their transplant, okay? In fact, today, in 2019, your chance of getting a heart transplant without an LVAD first is almost 0, okay? Because so many patients are implanted with these pumps now that they're the ones who are waiting for their organ, okay? So bridge to transplant's one option. Bridge to life, like just being alive, right? It's a bridge to the rest of your life. Bridge to decision. So you've got someone, a good example of this is maybe someone who is kind of a drug user, or you're not sure about their social situation, because having a transplant, right, you have to be very, very compliant. You got to take your immunosuppressions, you got to show up for your appointments. We've had a couple patients who are very, very questionable in terms of compliance. Sometimes I'll say, please implant the device, he's going to be okay. And what you find is they'll implant the device as a bridge to deciding, are you going to transplant the patient, or are you just going to let them live with their LVAD to the end of their life? And then there's bridge to recovery for some patients who have rip-roaring myocarditis or severe postpartum cardiomyopathy, something where you think the heart's going to get better, but right now they're not going to live without a pump. They'll implant the pump and hope that the heart gets better. That's a very small number of patients. The 2 most common reasons that patients are implanted is a bridge to transplant or bridge to life. Just they're going to live with the pump for the rest of their life, and that's that. So this is one of our patients. He's got all the things. He's got a defibrillator. You can see that this is done through a small thoracotomy and an upper hemisternotomy, and here's his thoracotomy and his upper sternotomy. Pumps here, and he's living his life with his VAD. He's back to work waiting for his transplant. This is the outcomes of these strategies for stage D failure. 2-year survival. So if you transplant the patient, their chance of being alive in 2 years is 87%, right? Because some of them are going to die up front from the surgery or something bad up front, okay? If you put in an LVAD as a bridge to transplant, so this is someone who's basically all their other organs work, right? To get a heart transplant, you basically have to have all your other organs work, right? So those patients get a pump, their 2-year survival is about 76%. If you put it in as a bridge to decision, that's the green, so you're not sure, the survival goes down. But what I want you to see is this, okay? If you just treat these patients with status quo, we'll just take off some fluid, keep giving your medicines, their chance of being alive in 2 years is basically 0, okay? And that, for this group of patients, is sort of where the hospice. And then the bridge, this is the destination therapy, someone who's not transplantable. So you put the pump in to say this is just going to keep you alive and you live your life. About 40% of those will be dead in 2 years, but 90% of them would be dead in 2 years without the pump. Okay, and how many people in rehab have bad patients that show up? Yeah, some of you do, and you know they're fine, right? They're like fine. They show up and they do their thing, and they're fine. Like everybody gets freaked out about them, but the pump is not. They're going to be fine. The pump doesn't fail. Okay, it's funny. They come to the ER and they call and they go, "We have a bad patient here." I go, "Yeah." And they tell me, I don't know, he's got a stomach ache or something. It's like they're all freaked out about it. And I said, just don't worry about the pump. It's going to be fine. Okay. Pardon?
Just don't unplug it.
Just don't unplug it, right? Yeah. And usually they come, they got all their stuff with them, their backup stuff with them. So they do fine. The next thing I wanted to talk to you a little bit about was just this idea of the hemodynamics of congestion. So I told you we always tell our patients to keep an eye on their weight, okay? If their weight starts to go up, we get worried. But if you go and you actually look at the hemodynamics of these patients, the pressures in the left ventricle, they start to go up weeks before the weight starts to go up. So if you look at this graph, okay, this is the weight change right here before the patient's hospitalized, 4 or 5 days before they're hospitalized. But if you go back 2-3 weeks and you were able to measure the pressures, you'll see the pressure starts to go up and up and up until they reach this point. Okay, so these people actually start to decompensate weeks before their weight starts to go up and before they get hospitalized. Okay, so if you had a way to detect this, right, if you could detect the pressure going up and do something about it, you could completely stave off this issue, right? So this is a little device called the CardioMEMS device. We implant them at Munson. Some places implant them. It's a little device, looks like this, and we implant it in the pulmonary artery. So we put a catheter up in the right heart into the pulmonary artery, release the device. The device lives in their pulmonary artery, and then they have a little pillow that they lay on up here in the upper right, and the device, the electronics in the pillow stimulate the device, and it measures the pulmonary pressure. So it gives me this exact waveform, which is the same waveform that I would see from a swan, okay? And it sends this to my iPhone, okay? So I get a report every day on what Sally's PA pressure is, okay? And you can see here's all the pressures on this patient. And we have, I don't know, probably 15 patients we've implanted with these devices, and I had to start turning off the iPhone thing. I let the nurses deal with it because I was getting emails every day about people's pressures. But what you do with this, right, is you start to monitor the patient's pressure, and then we'll see the pressure go up. The nurses call, what's going on? Well, we went to Burger King, but I feel fine, and my weight's the same, right? And the nurse will tell them, nope, you're going to double up on your Bumex today. We're not waiting until your weight starts to go up. And then the next day they send us their pressure, it's back down to normal. Okay? So this works very well. If you look at the studies that were used to approve it, this is just readmission rate out. This is 900 days, so we're talking about 3 years, right? And you can see these curves start to separate almost immediately. Okay? So having this device in place, it can be very helpful for the right patient, and is very good at reducing readmissions. It doesn't really improve their life expectancy because that's not what it does. It's not a treatment, right? It's just a monitoring tool. All right, now we're going to switch over to heart failure with preserved EF. So that was the systolic heart failure, meds, defibrillators, transplants, LVADs, all that stuff for those patients. This group of patients is much more difficult to deal with, okay? You probably have a lot of these patients in rehab and you don't know that this is what they have because they don't know this is what they have, right? So heart failure with preserved EF, or what we used to call diastolic heart failure, it's actually a very complicated problem, all right? So it's got all of this stuff that goes with it, okay? A lot of these patients have lung disease, COPD, they have anemia, they're older, they're obese, they have sarcopenia, they have muscle wasting, they have depression, they have all this other stuff. And then they have pathophysiologic correlates of that. Okay? So this is, the most common phenotype of this is an overweight, older woman who's diabetic, hypertensive, and says, I'm short of breath. That's exactly what they say. I'm short of breath. In fact, when they walk in, I'm like, oh God. Because it is a very difficult problem to deal with. And rehab actually is very important in this group of patients, but getting them to do it is where the difficulty is. So what happens with these people? The most important thing for you to know is having heart failure with an EF of 60% is just as bad as having heart failure with an EF of 16%. It's the same. These are the two survival curves. This is a group in Canada. Okay? People think because my EF is normal, I'm okay. You're not okay. The survival is exactly the same. Okay? It's almost exactly the same. And you can see 10 years, almost nobody was left alive in this cohort from Canada. Large group of patients, right? So having a reduced EF and having a preserved EF is basically no different if you have the clinical syndrome of heart failure. Okay. So the prevalence of this problem is increasing. So if you look at this slide, the dark blue is the percent of patients with heart failure who have a preserved EF. Okay? And you can see it's gone up considerably. Okay? Why is that? Because we save people from their heart attack, their defibrillator keeps them alive, different things happen. Okay? The diabetes epidemic, all of that stuff feeds into this problem, all right? So this is a big problem. The problem is that CMS doesn't cover rehab for this, which is one of the problems. But you will, I think it will, and I think you will see more people over time. So let's do a little exercise physiology, since that's what you guys, a lot of you are, and the nurses. What happens when you exercise? So in order to be able to have a good exercise capacity, right? If you look at the slide on the left, the blue is a normal patient, the blue. This is the stroke volume, right? Stroke volume is just how much blood's in the heart at the beginning, how much blood is in the end, subtract the two, it's the stroke volume. When you exercise, you have to be able to increase your stroke volume, right? You have to get more blood out with each beat in order to meet the demands of your muscles. So the blue bar here is rest. Here's the blue bar in a normal patient when they exercise, okay? The red is a patient with HFpEF, okay? And what do you notice? They do not increase their stroke volume very much when they exercise. That's the problem. That's why they get short of breath, okay? They cannot increase their stroke volume, okay? And so their exercise capacity is terrible. So they can't just not increase their stroke volume, but if you look at their chronotropic response, which was discussed in one of the previous talks, they have a blunted chronotropic response, right? So if you can't increase your stroke volume, right, what's the only way you can increase your cardiac output? You have to beat faster, right? If you're only beating this much every time and you don't beat faster, nothing is going to change, right? And so these people have a lot of chronotropic incompetence. And they're on meds usually that make that worse, right? Because I told you they have hypertension, they have all this stuff, so they might be on a beta blocker or a rate-limiting calcium blocker. It makes the whole thing worse, okay? And then the last thing they have a problem with is vasodilation. So you remember, in order to increase your cardiac output, your heart's got to beat harder, it's got to beat faster, and your peripheral vessels have to dilate so they can accept that increased cardiac output. And these people can't do that. They do not peripherally vasodilate like they're normally supposed to. They can't increase their stroke volume. They don't increase their heart rate. They have marked exercise capacity. These people usually tell you, you know, I make the bed and I got to sit down, right? I always say, can you take a shower without getting short of breath? Can you get dressed without getting short of breath? A lot of times they can't, okay? But they have a normal ejection fraction, right? So it's very counterintuitive when you see it. Because I have people who have EFs of 10 who go to rehab, right? And they walk on the treadmill and they do their thing. So ejection fraction is not the problem here. If you look at treatments, these are just all the studies that have been done looking at different treatments for HFpEF. And if you look at the far right, nothing. Nothing helped, okay? If you look, there are 7 class 1 recommendations for heart failure reduced EF. That's ACE inhibitors, beta blockers, spironolactone, defibrillators, all that stuff. There are 0 for this, 0, okay? And the question is, why is this, right? Why are cardiologists smart when it comes to low EF and stupid when it comes to normal EF in terms of trying to solve this problem? Probably because of this. So if you have a treatment that helps people who are this group of patients. So you have a bunch of people who have heart failure and their ejection fraction is normal. But within that group of patients, there's 3 subgroups. You don't know that, okay? There's 3 subgroups. And the treatment you're testing only helps subgroup A, right? So if subgroup A is a small portion, when you give the treatment to everybody and then you count how many people got better, you're going to say, well, gee, not very many people got better. It didn't work, okay? This is what the problem is. Okay? People are starting to realize now that not all these HFpEF patients are the same. There's different subgroups within them, and maybe we need to go back and redo all those trials looking specifically at subgroups of these patients, okay? So we're going to see how all that goes over time, all right? This is the HFpEF obesity phenotype. I told you obesity is a gigantic, that's kind of a pun, it's a gigantic problem, okay, for this specific group of patients, okay? There's a lot of stuff that goes on. A lot of these patients have sleep apnea. Some of it's just from their size. They have a lot of visceral adiposity, which leads to a lot of metabolic issues. They have fatty liver. A lot of these patients, if you look at the liver ultrasound, if you get on their computer, if you're looking at their records, you look at their liver ultrasound, a lot of times they'll say they have steatohepatitis or hepatic steatosis. They have kidney problems, which are a giant problem for us. And then they have problems with their peripheral muscles. If you biopsy their muscles and look at their fast twitch and slow twitch and all that stuff that I don't understand, you'll see there's a difference in these patients, okay? Diet and exercise actually helps these patients, but what I told you, they're like rocks. They're like impossible to get to go to rehab and impossible to get them to change. They're a very difficult group of patients to deal with. But if you look at, this is just looking at anaerobic training and calorie reduction in this group of patients, you can see basically the combination works the best, okay? Whether you're measuring peak VO2 or whether you're measuring how they feel, okay? And peak VO2 I think is a good measure because really what I'm trying to get the patient to be able to do is to do more than just survive, right? I want them to be able to go to Myers, go shopping, do this, whatever it is they have to do without having to use the little electric cart or without having to have someone drop them off at the door. That's what I want them to be able to do. And if you ask them up front, a question I always ask is this. I said, I always ask people where they grocery shop. If they don't say Myers, this won't work. But in Traverse City, a lot of people go to Myers. I'd say, oh, I go to Myers. I said, and I know that the milk is like, and the one in Traverse City is like in the back corner. I said, if you got to the checkout and you realized you forgot milk, what would you do? And if they say, oh, I wouldn't go back, I say, well, because it's just too far. It's just I get too short of breath, right? So you have to figure out sometimes how functional these people are. Because a lot of times I'll say, do you get short of breath? No, not really. But they don't do anything. Right? So you have to get kind of into the weeds with them and say, tell me do you have stairs at home? Like sometimes I'll say, do you get short of breath on the stairs? They say no. I said, do you have stairs at home? Well, no, I don't. So, and they don't ever take the stairs, right? So you have to ask them specific things, very specific things. And using the Meyer things, one thing that I do, there are other things. I said, if the elevator was broke and you had to go up 2 floors, could you do it? They'll say, no, I would just, cancel my appointment with the doctor and come back another day, right? So this works. A little bit about exercise training. As I told you before, EF does not correlate with the degree of exercise impairment. You can have a normal EF and be very impaired. Exercise training does improve all these things, the things I told you that are a problem. It is very safe in this group of patients. We have patients with ultra low EFs who go to rehab and they do just fine. Most of them, you gotta have a defibrillator, or you gotta have the human defibrillator. Somebody needs to be around, all right? But they have to have a defibrillator. And you can increase peak VO2 by a lot, okay? And I'll tell you, if you think 25%, maybe that's not a lot. If your peak VO2 is 8, okay, and you can get it up to 10 or 11, it's a big deal for patients like that. As I told you before, rehab is only covered for patients with low EF. Now, luckily, a lot of these HFpEF patients have coronary disease. They have something, they have angina, they have something you can kind of work with to get rehab covered. Rehab's not covered for an LVAD either, but they all have a low ejection fraction. Usually you can get it covered for that. You guys do reduce hospitalizations. There's no question that happens. I think you could do a better job by making sure a little bit about, are they doing self-care, talking to these patients, finding out if they say, we went out to a party last night, a little more short, I was short of breath when I laid down, tell them to call their doctor, okay? The most common reason these people get admitted is because something could have been done that was not done because someone didn't recognize it, right? There is, I hate to tell you this, you're not really saving lives, okay? In terms of rehab's effect on mortality in this group of patients. But it's not all just about saving lives. And the uptake is very, very low, okay? Our heart failure program, we harp on it constantly, and it's hard for us to get patients to go to rehab. We've been fortunate we've had some grant funding and some gifts to our foundation so we can pay for people's rehab if we have to, if they don't have coverage for it. This, I'm just going to show you this. I'm not going to go through it in too much detail, but this literally just came out in this last week or two. If you're interested, you can look at this, but I'll just give you the bottom line, okay? It's this. So these are forest plots. Some of you are familiar with these. All these are all studies. The red diamond is what you care about, okay? Because the red diamond has incorporated all of the studies into sort of a final thing. So at the top is, I think it's for, what's the top? Quality of life, and the bottom is exercise capacity. So basically, if this line touches, if the horizontal line touches 0, there's no effect, okay? And then if the horizontal line doesn't touch 0, like this one or this one, there's an effect. And where these are, also in the size of these lines, has to do with the number of patients in the studies. It's a statistical thing that is extremely boring, and I don't understand that either. I just know that if you look here, okay, cardiac rehab does improve quality of life, and it does reduce it does improve exercise capacity. There's no question when you add these things up, okay? And this isn't rocket science. You guys know this, right? People's exercise capacity tends to get better, okay? And their quality of life tends to get better because of that, okay? So I think rehab has a super important role in this exact space, okay? I can tell people you will feel better, okay? And your exercise capacity will go up if you go to rehab. I've been doing this 25 plus years. I cannot remember the time I sent a patient to rehab and they came back and said, that was the worst experience of my life. It just doesn't happen. It just does not happen. Now, they have a lot of reasons they can't do it. I can't go, I've got to work, it costs too much or whatever. But they never come back and say it was worthless or it didn't help me. Okay, so it definitely helps. This is our team. I'll just show you kind of how we do our program. So these are all the nurses that do everything, and I just come and talk about it, basically is what happens. But there's me, and there's a team of nurses and one nurse practitioner. If you look at the patients who get referred to our heart failure program, we're almost up to our 1,000th patient now. Before coming into our program, the average patient was admitted to the hospital 2.3 times in the previous 12 months. And then since being in the program, their admission rate is not even once a year, okay? And what I want you to know is I have nothing to do with this, zero to do with this. It's all those other people in that picture that do all this, and I'll show you why that is. Let's take this guy. This is a real person. Tom, he's 75 years old. He's got referred to us because he has heart failure with preserved DF, okay? Multiple hospitalizations, okay? So this is his comorbidities, just like I told you. Coronary disease, hypertension, diabetes, kidney disease. Been hospitalized 5 times in the last year, okay? During this last hospitalization, 30 pounds of fluid was diuresed. Now think about it. Somehow he got 30 pounds up, right, before he got in the hospital. So they take 30 pounds off, right? What happens? One of our heart failure team nurses goes to see him in the hospital. I don't see him. I do not see him. Goes to see him in the hospital before he goes home, okay? Because the most vulnerable period for these patients, I always say we're releasing them into the wild, right? They leave the hospital, and then they're going to come and see me on average of 1 to 2 weeks later. That period of time right there is the most vulnerable period of time. So I have our nurses go, they talk to him, and they say, here's what's going to happen. You're going to see Dr. Recchia in 2 weeks, but we're going to talk to you tomorrow, okay? We're going to write down your weight right now. They bring the scale. If they don't have a scale, we give them one, and we make them get on it in the hospital room. We say, that's your weight right there, okay? And so what happens? In the first 9 days before they saw me, our nurses talked to the patient 3 times, okay? That's what made the difference right there. They talked to the patient 3 times before I haven't even met the guy, okay? Comes and sees me. I say, okay, we're going to do X, Y, and Z, right? Pharmacist talks to the patient, the nurse. I'm in the room for 15 minutes. They're in the room for half an hour, okay? And they go through everything with the patient, figure out what their situation is. Do they understand what we're trying to do? Do they not understand what we're trying to do? How are we going to help this patient? And then we refer them to cardiac rehab almost universally, okay? Whether they go or not, it's different, but we refer. So what happens? So over the next 12 months, so this guy was admitted 5 times the previous 12 months. Over the next 12 months, what happens? 13 phone calls in the first month. I have nothing to do with that. I'm doing my thing, my other cardiology stuff. I don't even know this is going on. 13 times they talk to him in the first month. Then they call him once a week for the second and third months. And then once a month for the next 12 months, he sees our nurse practitioner 3 times in 6 months. I see him at 9 months, right? And he has had 0 hospitalizations, never felt better, okay? This is not advanced medicine. It's not. It's not even, I'm not doing any of it, okay? It's just this group of patients needs this in order to stay out of trouble, okay? And that's what I'm saying. If they're coming to rehab, you're seeing them more than I am, right? So you have to know what to look for, and you have to know when to tell them that they might want to talk to their cardiologist about what's going on, okay? You can send us a message and all that stuff, and sometimes that works, sometimes it doesn't. It's better if the patient calls, okay? Or if the patient knows how to use a flexible diuretic regimen. So they've been told, oh yeah, they told me if my weight goes up, I'm supposed to take some extra Lasix. Something. Say, maybe you should do that, okay? Maybe you should do that, okay? And you'd be surprised, especially if they come to rehab on a Friday, okay? Because now they got the weekend, right? So that's what I had to say. I'm happy to take questions now, or I'll stick around for 10 minutes and take any other questions that anybody might have. Question?
I just want you to put that slide up that had the guy on it with all the,
Oh, okay.
that would be great.
Remind you of someone, or?
Yeah?
All right. And if you just, Denise has my email. You can always email me, and I think it's this one. This one?
Yes.
Yeah. You can. I can just send you these slides too, if you want. Other questions? Anybody? Where? Go ahead.
Which patients are eligible for the MEMS device?
Basically, they have to have been admitted within the last 12 months, and they have to have, the EF doesn't matter. And then there's some other things, like they can't be too big, because the device won't work. They can't have had a DVT or a PE. There's a few other things. They have to be able to take dual antiplatelet therapy for a while, some other things like that. Let me do her. Is it related or a different question?
Yeah.
Go ahead.
Why doesn't that help them live longer?
So the question is, why doesn't the CardioMEMS device help them live longer? Because it doesn't treat anything, except we just monitor them for congestion, right? So their underlying disease process, their coronary disease, their low EF, that stuff's not changed by it, right? So if you look in cardiology, like putting a stent in or doing a bypass doesn't make anybody live longer either, right? That's been shown over and over again, right? Unless they have left main disease or triple vessel disease. But your average patient who comes in with an MI or who has angina and we put a stent on their right coronary, we're not improving their life expectancy by doing that. Does not make a difference life expectancy-wise. You had a question?
Yeah. First, great presentation. Thank you.
Mm-hmm.
With the HEF patients,
Mm-hmm.
is there data or can you speculate on those subcategories that you alluded to?
All right, so the question is on patients with HFpEF. You're learning the terminology, very good. Is there a data on subgroups? There is, okay? So if you look at that group of patients, preserved EF heart failure, there's usually the 3 groups in there. There's the patients who have what we used to call diastolic dysfunction. They have good kidneys, no pulmonary hypertension. A lot of times they have coronary disease, and they just get short of breath when they do stuff. Those people do pretty well. Then at the far end is you have people that have pulmonary hypertension, bad. So the high pressures on the left side have now transmitted backward. Now they have pulmonary hypertension. Now their right ventricle is failing. They usually have bad kidney failure. Those people do horrible, okay? So if you were gonna, and then there's a middle group, which is sort of, you can imagine, is in between. So if you're gonna treat patients, treating the far right group, the ones that are already far into the disease process, they're probably gonna kill your numbers, okay? Literally, right? They're gonna die and they're not gonna do well. So the idea here is, can we develop a way to refine these patients and figure out who are you, and then study that group of patients, right? So I think the benefit is probably going to be in the earlier group of patients, identifying this earlier. I cannot tell you how many people I see who are short of breath. They get sent to me because they're short of breath. This is what they have, but nobody thinks this is what they have, right? They all think they have coronary disease, or they all think that they're moderate aortic stenosis is why they're short of breath. It's not. In fact, we're finding in the TAVR group, so we do a lot of TAVRs at Munson, and basically, if you look, there is a group of patients who get a TAVR, right, transcatheter aortic valve, who don't get better, and what they have is HFpEF, and that's what they have, okay? And you fix the valve, and you just leave them with the same way that they were afterwards. Yeah. Other questions? Go ahead. Gee, you're
Unrelated. With your program that you mentioned, you're not a part of it until that 9-month visit. Is that available, or are you grant funded for it?
So the question is about our program. It's all that's billed, okay? grant funding started it. So one of the nurses and I hatched this idea actually one day, and went and approached our foundation. So look, we got this idea. And they gave us some money to get going. Everything else we bill for everything we do. So the nurse practitioner, the phone calls are not billed for, right? So, but if you have a savvy hospital CEO and board, and you say, look, this guy was admitted to the hospital 10 times. Half of those admissions you're not getting paid for or that you lose money on. Now we keep him out of the hospital. There's value there. Right? All right, thanks. Thanks for the opportunity. Appreciate it.
Thank you so much. Excellent.
I'm sure you want to stay for lunch.